The angiojet, we use it in the peripheral world even till now, and that it's not a favorite device anymore, even in the peripheral world. But in the coronary world, clearly, there was trials showing harm, so that's why people have stopped doing angiojet altogether. The hunger of having data that's positive, I think why CHEETAH became, you can call it a landmark trial, even though it's a single arm, study. Everybody got excited about CHEETAH. People started practicing differently after CHEETAH using mechanical thrombectomy. Can you summarize to the audience your reaction to the CHEETAH trial from a design perspective, from a data perspective? How do you look at it, and how do you implement it in your own practice?
Yeah, so CHEETAH was a multicenter study from Penumbra, published in 2023, that essentially, because prior trials had not shown a clear benefit of routine manual aspiration thrombectomy, as we said, they thought that a sustained suction might be the answer, and so they conducted essentially a similar trial design. They had 389 patients, and their stroke rate was 0.77, which I think corresponds to 3 strokes total in the trial. They had no device-related serious adverse events, and so they said, this is a win. It goes back to potentially one of the issues we had with thrombus. Thrombus was only 1,000 patients, right? This CHEETAH was only 400 patients, right? So the stroke rate is low, but what's the statistical significance of a trial of that size when you're trying to extrapolate to a very common event, right? STEMI is very common. I can tell you, we've had a major snowstorm over the last couple of days. Yesterday, we did 6 STEMIs at our center. And, we're talking about a lot of people who could be at risk of having a stroke if you extrapolate this incorrectly to the entire population.
I think the biggest thing for it is that the way they designed the study was actually very smart, learning from the total. Some of the things that important is that you have to have a good engagement, coaxial engagement with the guide. Guide cannot be flopping in the aorta. And that continuously. You have to have a continuous negative suction out of the body. You have to waste some blood afterward. All the steps that we have been practicing in the manual aspiration, but I think adding the mechanical suction with a negative, I think minus 29 continuously helps. I think from the data, what they present the data, maybe I'm not correct on that one, is that the intrahospital stroke was 0. I think it's a 30 days stroke.
It was a 30-day stroke, exactly.
Yeah, 30-day stroke is what came out as 0.77. And I don't think they were able to do a full study, because cardiology is always, we want thousands and thousands. We used to thousands and thousands and thousands of patients. And I don't think any company has the capacity to do a study like this. Have you, in your own practice and your team practice, changed from selective thrombectomy, from using manual to using the mechanical thrombectomy nowadays with this technology?
In general, I think we favor the mechanical. There's the theoretical, maybe we have a lower stroke risk because we have continuous suction. There's the theoretical that because we have continuous suction, maybe we're able to suck across a longer segment of vessel, which may be favorable as opposed to just the limitations of the duration of suction from the catheter. And then there's a reason, I guess, I wish weren't, but is, and I guess that reason is 37184, which is the CPT code for mechanical thrombectomy, right? Mechanical thrombectomy is a reimbursable procedure and manual thrombectomy is not. So, there are pressures from administrators to do something that makes money, not costs money. If it's better for patients and the hospital gets reimbursed for it, it's 2 wins.
The third one, I think, that you pointed out real briefly, and it's important to discuss, is we always look at TIMI, this is TIMI 0, TIMI 1, TIMI 3, but, myocardial blush degree has been correlating better with survival. And I think we lack the utilization of it, just unless you're academic. But have you noticed that you're having, in the study, it showed higher MBG, myocardial blush grade, F2 and 3, and they're also the whole patient population. Are you seeing that when you're doing a mechanical thrombectomy prior to ballooning and not in a rescue situation?
Yeah, I think it's a pretty rare practice, I think, to thrombectomize without any balloon at all first. The situation where the coronary is occluded and you're not sure what the thrombus burden looks like, what the distal vessel looks like. And so you at least want to put a little balloon in, get some flow down the vessel, put some contrast in, and find out what you're up against. I don't know that as an individual, I can say that I have enough experience in the myocardial blush grade. If I think about the last 20 cases I've done with and without thrombectomy, I can't say that I feel a difference there. And that's why, when you look at study level data and the myocardial blush grade differences are small numbers of percents, you understand this helps over a population, but not at the individual patient level. I think in general, we may still be at a point, and this is arguable, but are we at a point when there is still equipoise, thrombectomy versus no thrombectomy? CHEETAH is a useful data point, right? But CHEETAH is not a randomized study. It's a single arm study, right? If we want to continue from topless taste and total, if we want to know how that works with mechanical thrombectomy, maybe we need to randomize them patients.
Yeah, I mean, I think, to my understanding, the company has tried to do so, but FDA has requested thousands of patients, and I don't think that's financially feasible. Before 2025 was not billable. Thrombectomy was not billable. 2026 now it's billable, which may change how people look at it. But I think it's really important to figure out